Hi everyone, I'm Dr. Glossy Sabharwal, Course Director at Iqramed Ultrasound Academy. We are here today to tell you each and every detail about setting up a breast clinic. A breast women health clinic is one of the most important, demanding, and it is required for especially in post-COVID era where the incidence of breast cancer has increased in the young population. As a doctor, whether you are doing MBBS practice, whether you're a physician, whether you are a gynecologist, a radiologist, or imaging specialist in any other field. If you have interest and you are looking forward to setting up your own breast health clinic, then this course is a must for you. We will tell you exactly from the minute the patient walks in a clinic. If you come across a patient who's feeling uncomfortable in the region of the breast or is feeling a lump or is feeling pain in the breast during her periods, she will come to you for a checkup. How you have to start from the point the patient walks in, how you have to make her comfortable and give your best clinical diagnosis till the treatment is what is important, and that will be covered in our course. From setting up the breast clinic to precise diagnosis and treatment will set you apart from other clinicians when it comes to breast imaging. We will also discuss in this various common procedures that aid in the diagnosis of breast lesions, like ultrasound guided fine needle aspiration cytology, ultrasound guided core biopsy, and many other conditions. We will tell you how to set up the interventional breast conditions in case you are interested in doing interventions in the breast, which is like FNSC or core biopsy, then how to set up the tray, how to take the patient history and consent. Because these are common things which you should know as a clinician if you are specializing in breast imaging. The first and foremost, as the patient walks in the breast clinic, is the history of the patient. Whether the patient comes for a routine checkup or is coming with a high risk, you have to take a detailed history. If you have a setup where there is a lot of rush and you are not able to give time to each and every patient, then it is better to get the file of the patient before and have a proforma filled in which there are risk factors. What are the risk factors for breast disease? And when we say risk factors, we are not only talking about breast cancer, we are talking about breast diseases in general, which includes benign to malignant, all the conditions. So we have got two ways to divide the risk factors as we have done it in our clinic. There are modifiable risk factors and non-modifiable risk factors. While we are talking about the risk factors, we divide them into two categories, modifiable and non-modifiable. Modifiable risk factors, as the name suggests, are the ones which you can modify, they are in your control. Like obesity, maintaining a proper BMI appropriate for your age, for your height, is very important. Then your smoking habits, alcohol consumption, refined sugar intake, and exercise are some of the factors which you can control and make the breast health better. If you are taking HRT, you must understand what are the indications for it. Do not take HRT just over the counter without understanding the risk factors. The ones with estrogen and progesterone to increase our risk. So we have to evaluate that the breast is absolutely normal before taking any HRT. So these are some of the modifiable risk factors. Then the non-modifiable are your genetics. You cannot do anything about it. Your reproductive history, whether lactation happened or did not. If it happened, whether you did or not. But happening of lactation reduces the risk of breast cancer. So some things which are genetically made you cannot modify, but you have to ask the patient and then categorize the patient that, okay, this patient comes in low risk, medium risk, or high risk. Then comes the age of the patient. If the age of the patient is less than 40 years, then we do not recommend getting a mammogram done. But ultrasound has to be done in every patient. In dense breasts, if the breasts are very dense, then mammogram is not alone helpful. We have to still do ultrasound breast along with it. In short, ultrasound is one modality which is without radiation, easily available. It's cost effective for the patient, gives a lot of information if done by an expert. You can actually give your patient that boom of early diagnosis if you know how to do a correct breast ultrasound. Sometimes you will get pediatric population also, young girls who are developing the breast tissue or have early periods, early menarche, less than 10 years of age. Sometimes have very painful budding breasts. They can really get anxious about it if you, as a clinician, as their doctor, do not know what to do. So, you should understand that it is very normal for the developing breast to develop pain. The budding breast tissue can develop sometimes an abscess, sometimes a disease which is known as fibrocystic also. It is not that common, but it can happen. Also, if there is injury, there can be hematoma. So you have to be careful and aware that ultrasound can be used at any age and stage to evaluate breast pain. As we discuss further, as the patient walks in, you talk to the patient about the clinical details and assess the risk for breast disease. Apart from that, you will ask the patient that are you doing self-breast examination? What is the importance of self-breast examination? Every female must know how to do it and when to do it. The correct time to do self-breast examination is after your periods. So if today, for example, you start your periods, after the periods get over in 3, 4 or 5 days, that week is the time you do your breast self-examination. The correct way to do it is you can use some oil, some cream. Consider your breast as a clock. We will show you on a model of how to do self-breast examination. If you consider this as a breast and this one is 12 o'clock position, we go clockwise. So if we are going clockwise, then this is 1 o'clock position. This is 2, 3, 4, 5, 6, and similarly till 12. So we evaluate breast in clockwise position. The best way to do it is these fingers. You can use 3 fingers or 2 fingers. The tips of the fingers are the most sensitive one. While you are examining the patient, you can also teach the patient how to do self-breast examination while you yourself are doing patient's clinical breast examination. The best way to start is from the outer edge towards the nipple. Using 2 fingers, you go clockwise and anti-clockwise with medium pressure, feeling the breast parenchyma tissue under the tips of your fingers. You do at 12 o'clock position, 1 o'clock position, 2 o'clock, 3 o'clock, likewise. If you find something, you make a note of it. Always tell your patients to do the self-breast examination after they go from your clinic, because then they would know that this is how the normal breast feels like, or if there is a cyst, how it feels like, if there is a fibroadenoma, how it feels like. After evaluation of the breast tissue, you have to also tell the patient that the breast tissue has to be evaluated along with the axilla on both sides. Why? Because the breast tissue is made in a way that a part of the breast tissue, we call it the axillary tail of the breast tissue, it goes into the axilla. That also needs to be examined. The same way, tips of 2 fingers, you will examine the axilla of the patient. Also teach the patient how to examine the breast. The last step in breast examination is you squeeze the nipple with a very light pressure to see for any discharge. Any sort of nipple discharge, whether it's milk, whether it's fluid, whether it is yellowish or it is reddish, has to be noted down. And similarly, you will educate the patient about it. When we are doing breast ultrasound, the positioning of the patient is very important. You have to make sure that the patient is comfortable on the bed. If the patient is not comfortable, then the scan will be obviously limited. When the lady is lying down, you have to make sure you have a setup where the bed is very comfortable. You have a medium size to large size pillow, and you have a curtain to cover so that the patient is on the other side with the machine and with you. And you can always ask if they want another female attendant to accompany them. The comfort of the patient is very, very important. Otherwise, for you to make the diagnosis will be very difficult. Once the patient is comfortable, you have to explain the procedure that you will be undressing from all over the top, because you cannot have not examine the axilla. You have to examine the axilla, you have to examine the breast tissue, you have to examine the whole of the chest area. So the patient has to undress from the upper half of the body. Telling the patient that, taking a consent and going ahead. Now, as the patient is on this side, we have a demo breast, how to position the patient. Unless you position the patient correctly, the lesions can be missed. Now, when the patient is lying down, supine, you have to make sure that the neck of the patient is at this level, the face is here, and the chest is coming like this, so that the breast tissue is exposed exactly how it is on this pillow. As you can see, this is the pillow. So the patient will be, you can tell them to flex the legs so that they are comfortable. And you put a green sheet that has a hole in it so that the breast tissue is completely seen. Or you can even avoid that. You can just make sure that the patient is in this position, undressed from the top part. Why do we want this position? Because we want the arms to be stretched up from the axilla. Imagine this is the axilla and the breast tissue. So we have to examine the axilla and the breast tissue. We will tell the patient to keep the arms over the head, and then we start our examination from the ultrasound perspective. As I have told you before, for the breast we have to consider a clock position. This is 12 o'clock position. 1, 2, 3, 4, 5, 6 o'clock position, 7, 8, 9, 10, 11 and 12 o'clock position. So we are going clockwise. Similarly, in this we will use the ultrasound probe and we will go from the outer margin of the breast towards the nipple from 12 o'clock position and so on as a clock. There are various ways to do the breast ultrasound. Number one is that we go radial. Radial means that we are at a tangent of this. This is the radial position. We'll go from the outer to the inner part like that, clockwise. This is called radial ultrasound position. Make sure that your right is correct towards the right of the patient, towards your right hand, which is left of the screen. Then the other probe movement that you have to see is the transverse movement. That means right to left, left to right. This is transverse. This is the transverse position. The third position is longitudinal. You are going longitudinal. Now what is the difference between radial and longitudinal? See, longitudinal I am doing like this breast. Radial I am doing oblique. So longitudinal position. Radial is the one which we do clockwise. Transverse we are going to do from top to bottom. Longitudinal we are going to do from lateral to medial or medial to lateral. Then we will also cover the axilla in a oblique position. This will cover the axillary tail and the whole of the breast. So these are the probe movements which you should know how to do. How does normal breast tissue look like on ultrasound? As we have shown you the technique how to do it, now I am going to show you how a normal breast ultrasound looks like when we are using a linear probe with 10 MHz frequency on Samsung V7. So if you look at this image that I have taken just now, that how it appears, this is normal breast tissue. It has got, we divide the normal breast tissue into 3 different zones. One is the pre-memory zone. If you look at this image right here, this top layer which is echogenic is the skin layer. Normally, this layer has to be less than 2 millimeters. If it is more than 2 millimeters, then we know that there is some skin thickening, some underlying pathology, or there is some irritability or infection or inflammation. So this is the pre-memory layer, the first top layer that you see here. Then comes the memory zone. Now this is the memory zone of the breast. So pre-memory, memory zone. In the memory zone, what do we find? Where there is fibroglandular tissue. This is how the normal fibroglandular tissue looks like. What separates the breast fat appearance than rest of the fat in the body? Whenever we talk about fat in the body and ultrasound, it is echogenic. But the breast parenchyma fat is hypoechoic. That is where the difference is. So what you see in between these hypoechoic, this is breast parenchyma fat. Breast fat is hypoechoic on ultrasound. That means it is black. That means it's dark. Not like very, very black like fluid, but it is grey and dark. So it is darker than the fibrous tissue. And Cooper's ligaments and fibrous tissues are seen as these strands that you see, the echogenic strands giving shadowing in between. So if you know how the memory tissue looks like, then you will be able to pick up abnormality. These are absolutely normal small ducts which are seen end on. The end-on ducts will be seen as anechoic cystic structures. When you put color, they will not pick up color. That means that they are the ducts in the breast parenchyma. So all of this comes in the memory zone. Then comes the retromemory zone, where we find the pectoralis muscle, where we find fat, again this hypoechoic fat. So you see the fat component, predominantly the retromemory area has fat and pectoralis muscle. Here would be the ribs giving posterior shadowing, and in between is the intercostal muscle, pectoralis muscle, retromemory fat, memory area which has got Cooper's ligaments and the glands, and the pre-memory area which is the echogenic layer of the skin. So this is how a normal breast looks like. However, there are also normal variants. For example, if the patient is a lactating mother, then how it would appear. If you get a patient who is a lactating mother, then the concern sometimes arises about the dilated ducts. How you are going to examine them and what is the cutoff. If you look at this image, this is of the mother who is actively lactating. Now she came with slight pain and discomfort. Thankfully, there was nothing. This is a normal breast ultrasound in a lactating mother. What do we see here? We could palpate some lump. Actually, that was lactiferous sinus. The dilated duct in the lactiferous sinus can sometimes be confused for a mass. If that is the thing, ultrasound is the modality because it will differentiate between a solid mass and a cyst. So lactiferous sinus, which is a normal ductal dilatation, can be seen in the breast here, this area. So again, the pre-memory area, the memory area, and the retromemory area, where you see the pectoralis muscle and the fat. And these are the ribs, intercostal muscle. So this what you see here are the normal lactiferous sinus and the dilated ducts. These are absolutely normal. Do not get confused. Carefully look at the difference. This is dilated duct lactiferous sinus, the hypoechoic cystic structure. Very, very black, like literally if I talk in layman, then it's a black structure, fluid, clear fluid, whereas fat is grey or hypoechoic. So understand, fat is hypoechoic and this is cystic, or this is the fluid containing duct. So we have got dilated ducts, normal lactating breast. If you know the normal appearance of the breast, you will be able to pick up the abnormalities better. Now the next case that we have is of a patient who is 30 years old. Now this patient came to us with complaints of breast lump. Sometimes she is feeling the lump at 11 o'clock position, sometimes it is 2 o'clock position, some month it is not seen. What is it? And it's bothering her. She is just 30. If such a patient is coming to you, what will you do? She is 30, you cannot do mammogram. you will have to depend on your ultrasound skills. So let's see what were the findings in this patient. If you look at this ultrasound, we see the normal memory zone, pre-memory zone, we see the normal memory zone, but what we do see is that there is a hypoechoic mass. Further screening of the breast showed another hypoechoic mass. Now there is no posterior shadowing if you look carefully. There is no posterior shadowing, that means that there is no calcification. There is no posterior acoustic enhancement, that means this is not a fluid containing mass. Then what is it? Which is a hypoechoic, oval, well defined with minimal peripheral vascularity, and the vascularity sometimes is not even picked up. Multiple places, these are small fibroadenomas. The commonest breast masses that we see. They are benign, they keep changing their position, they are mobile, they are not fixed in the breast parenchyma, and that is how we differentiate them from other conditions. So how does a fibroadenoma look like? A typical fibroadenoma is well defined, hypoechoic, solid mass lesion with minimal peripheral vascularity, or sometimes no peripheral vascularity is seen. So such a case is seen in young females, but you have to remember also one thing, that these fibroadenomas can also sometimes enlarge and become very big and painful. In such conditions, we have to do an FNSE or a biopsy to rule out any malignancy. So fibroadenomas also must be kept under surveillance from 6 months to 1 year of ultrasound with monthly self-breast examination. Unless you are telling patient this, you can miss important breast lesions, and you do not want to be in that spot where you are missing early breast cancer. The next case that we are going to show you is a very important case, but I would really want everybody to have a focus here on the screen when I show the case, because this patient was misdiagnosed outside and she was treated for a benign fibroadenoma. For about 2 to 3 months, she kept on taking Evion, LC and Primrosa, but slowly she could observe that the lump was growing in size. Within 2 months, the lump from a size of a pea grew to at least 2 centimeters plus. What we saw on ultrasound was shocking because she was just 45 years age. This female had a lump 3 to 4 months back, and it grew very fast, which made her come to us again for a second opinion. On ultrasound, what we see is shown right here on the image. We see a mass which is irregular, a mass which is solid, which has got intense vascularity, microlobulations. If you see, these are the small lobulations, and the lesion measures approximately 19 into 14 mm. What do you infer from this? Firstly, how do we know that is it solid or cystic? Because if it was a cyst, it would have given posterior acoustic enhancement. What is posterior acoustic enhancement? When a lesion is a cyst which is fluid filled, it gives posterior brightness. The shadows, the bright shadows fall like a curtain from here down. That indicates that it is a cyst, but this is not a cyst, so it is a solid mass. Put in a color, you see intense vascularity, distorted intense vascularity within the lesion. In the core of the lesion, it's not peripheral like a fibroadenoma, so it is intense. The third feature, very important, is you look at these lobulated margins of the lesion, and some of them are even spiculated if you see carefully. They are spiculated, they have an angulation, and they are lobulated. Such margins to be seen, we of course need a very good resolution machine. For this, you have to have proper zoom, the time gain compensation has to be accurate. Then only you will be able to pick up the lesion. Otherwise, this can be missed as a fibroadenoma or an atypical fibroadenoma and given a pass. So this case, we did a core biopsy and it turned out to be ductal carcinoma. The importance of breast ultrasound. The patient was not affording to get a mammogram done. and the breast was very dense. In dense breast, even mammograms can miss lesions, can miss malignancy. But when we do ultrasound, we can see it how it is. Also in such a case, it does not end here. You have to make sure you have examined the breast. Now what are you going to do? You have to examine the axilla. And why is it important? Because we have to do the staging of the tumor. If we do not do the staging of the tumor, our scan report is incomplete. So we looked at the axilla of the patient. When we saw the axilla, what we saw was enlarged node. One enlarged node. How do we say it is enlarged? In breast axilla, you have to, in breast related cases in the axilla, our upper limit for the lymph node is 10 millimeters. If it is more than 10 millimeters, we consider it enlarged. We have to see the hilum. If it is fatty hilum means that it is echogenic. Echogenic means that it is whiter, not darker. So like in this case, that means that this is, the node is definitely enlarged. Why? Because look here, it is showing 21 into 10 mm. That means one dimension is 21 mm. The longest dimension should not be more than 10 to 12 mm. So this is 21 mm. So definitely node is enlarged. But at the same time, we see that the fatty hilum is maintained. Also, the cortex is very important when you are looking at the lymph node. So if you look at the lymph node, the cortex should not be more than 3 to 4 mm in an enlarged lymph node. So this lymph node is enlarged, but we will write, how will we report it? That there is a breast mass seen and there is enlarged single node in the same axilla, right or left, whatever the patient comes with, whichever side you are examining. And you will say that the node is enlarged, measures this in this mm with maintained fatty hilum or lost fatty hilum. Lost fatty hilum tells us a direct thing that this node is involved in malignancy. If the fatty hilum is maintained, then we can still think that okay, maybe the node is not involved or it is not seen as a frank involvement of the node. Any which ways, after in excision biopsy, we do sentinel lymph node biopsy to see the involvement of the node. So that is how the case is diagnosed as a BI-RADS 5. We will talk about the BI-RADS reporting on ultrasound in our next lecture. If you want to start doing breast interventions at your clinic, what all do you need? This simplest setup that we have here will give you access to do fine needle aspiration cytology, send the sample in the syringe to the pathologist for the checkups, for the detailing, for the HPV. At the same time, you will be able to do core biopsy under ultrasound guidance, and you can send the sample to the pathologist for HPV. This simple setup that we have created, I will just quickly show you before we start the procedure. That for the fine needle aspiration cytology, first and foremost that you need is your linear probe, ultrasound probe, because you will localize the lesion with this. You need betadine solution, you need gauze piece. To hold the gauze piece, you will dip it in this, clean the probe through this, then you are going to hold this, the second gauze piece, clean the patient with betadine, throw the gauze piece, keep the rest handy. Then you will pick up the syringe. Now you have localized where the lesion is, and with the syringe you are going to use and puncture the lesion, aspirate the fluid. We will show you how to do it. Just see the setup right now. In the syringe you will take the fluid and you will not pour the fluid somewhere else. You will send the syringe as such to the pathologist. This is for the fine needle aspiration. Now, in case the fluid does not come and you have to make slides, then what do? Then it is always recommended to have the pathologist or the pathology technician to make the slides, because your one hand is busy with the ultrasound probe and with the other hand you cannot leave this and then make the slides. So you do the fine needle aspiration and you give it to the pathologist to make the slides, and you are done with the FNSC of the breast. For the breast biopsy, what do you need? First and foremost, take a 2 cc syringe after cleaning the probe with betadine and the patient's site, localizing the site, marking it. You are going to then use 2 cc syringe to fill in lignocaine. So we use 2% lignocaine, and this we will put before doing the biopsy at the site that we have localized. After giving this, we are going to give a small incision. This is the blade holder, and we use 11 number surgical blade. Give a very small nick, we will show you how to give that. With that, we will use, through that nick, we are going to use the BART Max Core disposable core biopsy gun. This is what we use. Now we have to show you how to use this gun. This is very simple to use. It is automatic. It has got a depth of 22 mm. How you have to use? This is the neutral position. Now when you have to insert the gun, you have to pull one trigger, second trigger, and then you insert at the site. Once the site is finalized, under the ultrasound probe, you will then shoot, you will fire, and then take it out from the patient's site. Then the sample, which can be formalin diluted, you will open that bottle and you will carefully see that there is a blade here. Carefully look at this. You will pull one of the knobs back and the tissue will come here, which you will put in the formalin. And if you want another site, then you will again take with the other site. So that is the basic setup that we have. After the biopsy sample is taken, how to control the bleeding? With the gauze piece, put pressure. You will put pressure for 2 to 5 minutes at least, depending on the thickness of the breast, depending on how the bleeder is, how big the lesion was, how much nick did you give. After that, once you put the gauze piece over the surgical incision that you gave, you will put the Dynaplast because it gives pressure. We love to use Dynaplast. We put it over the gauze piece, secure it. It makes sure that the breast tissue does not move, patient does not have pain. Now, this is our basic setup. We will show you how to do the fine needle aspiration from a cyst and how to do ultrasound guided core biopsy. Now we are looking at the breast tissue and that shows a well-defined cystic lesion. Now, carefully look, my probe is in the transverse position and this is the right of the probe. It can be seen on the screen left side because this is the right of the probe. To do fine needle aspiration cytology, you have to use a needle according to the depth and you have to place it parallel to the probe. If the needle is perpendicular to the probe, then it will come as end on. Let's see how. Now this is my probe and I am going to insert it. First I will just do a little prick so that I know where I am. Do a little movement as you can see on the screen also, and then go straight in. Now in this way my needle and the probe is parallel. But if it is not parallel to this, then it will, if I do like this, this will come end on. But I have to keep it parallel to this. That means that this and this needs to be parallel. If I put it like this, this is end on. If it comes like this, it is parallel. So my direction of the probe and this needs to be parallel to each other. So if this is the probe, it has to be parallel. How am I going to keep both of these parallel? Look carefully. This is my transverse position of the probe. I'm going to go like this so that I'm parallel, making sure that I am not touching the probe also, otherwise it will spoil it. Any sharp object will spoil the probe. So we have to be careful that way, but we have to keep it as much parallel as possible. Now keeping the needle parallel, we give a little push just to see that this is the site as you can see on the screen. Zoom it enough, then you put your needle parallel. You can see the needle coming in. You can appreciate the needle coming in, and the needle gets inside the lesion like that. And see how the lesion has got busted, and we can aspirate the fluid, and the fluid aspirated can be given for sampling. So let me show you the video back again, what we have just now did. Keep looking at the screen carefully. See how the needle has gone inside. This is the needle going inside, and it is puncturing the cyst, and we aspirate the fluid. In certain cases, we have even treated the fluid, the fibrocystic breast disease, with this. So this is simple as that. Then you will close the needle like that, and the same will go for the sample pathology testing. This is simple how to do fine needle aspiration cytology. Now to do the, look at the image, what do we have here? We have a mass. It's a solid mass. We can see that it's not cystic, it's a solid mass. We have to do a biopsy of that mass. Firstly, keeping your needle again parallel, you can see the needle very close, and here we are giving the lignocaine. See, look at this, how the breast tissue is showing the lignocaine being inserted. You can see it very well, and we take out the needle. Now let the lignocaine act, because that will be our site where we give a nick, and after giving the cut, we are going to insert. This is our biopsy gun, as we have shown you before. This is our biopsy gun. You can see it well. This is the gun that's going inside the lesion. This is the solid mass. We keep it parallel to the probe, doing a slight maneuver, oblique, anterior, posterior, depending on the lesion, and we can see that it has gone inside the lesion. Once it is inside, you will not go through and through. You will wait here, and then you will fire so that you get the tissue core from inside. And once it has shot, the shot is taken, we slowly take it out like that. You can see it. That's our track of the biopsy taken. You can see that. Then you will put the gauze piece, and you will see how the sample comes. It is important to see how the sample has come. We can show you here. Now, whenever you have taken the sample, you have to make sure that how it is protected and completely it has to be conveyed to the pathology lab. How? Put the formalin solution container slightly lower your level so that you can actually see that everything is going inside. Then you will open this. Now carefully look at this. This is the breast tissue. You will dip this breast tissue inside without damaging further, and that's all. You can see that the breast tissue has gone in the formalin, and very nicely it can be assessed now.